today for cardiology grand rounds. I think for many of us here, he really needs no introduction, but still I'll try my best to highlight some of his accomplishments. So Dr. Scheinman is the Walter H. Shorenstein Endowed Chair in Cardiology and Professor of Medicine at UCSF. He's a true pioneer in the field of electrophysiology. Born and raised in Brooklyn, he completed his cardiology fellowship at UCSF in the 1960s, which I'm sure was a very different experience than it is now today. He is best known as the first person to perform catheter ablation in humans, and over his career has advanced therapies for long QT syndrome, pacemaker, and genetic arrhythmias. Additionally, Dr. Scheinman is also an exceptional educator, a recipient of the Henry Kaiser Award of Excellence in Education, and he continues to generously share his time and expertise with fellows at the weekly EP-ECG sessions. So we're incredibly fortunate that Dr. Scheinman is delivering today's talk on the management of long QT syndrome. So without further ado, I'll hand over the mic to Dr. Scheinman. Thank you.
Thank you very much, Evelyn, for a kind introduction. You brought back memories when you said that I came here in 1965, not 1865, as some people will say. At that time, we had a faculty of 4 in all cardiology. Now, what do you have? You have 90. So we were very busy then. We had 4 people to take care of everything, as Nelson will attest to. So anyway, I'm happy to share some thoughts about the long QT syndrome. And we'll be talking about both congenital and acquired forms. So this is the typical EKG, and the history is, in fact, one of our patients who came in with a family history of a sudden death, was seen in the emergency room after a syncopal episode. And the thing that, of course, strikes you are these enormously long QT intervals. You can make the diagnosis from the back of the room. Now, the cornerstone of diagnosis is the EKG, and we'll go over the details of how to measure the QT interval. But just for the basic idea, for males, we take greater than 450. Corrected QT is abnormal. For females, is 470. Apparently, the estrogens will tend to prolong the QT, so the normal QT for females is a bit longer than that for the males. Now, in measuring the QT, use either leads 2, V5, or V6. Invariably, lead 2 will be the longest. It's the longest QT that wins. You will want to avoid using V2, V3, because those are the leads that give you U waves, and you don't want to include measurements of the U wave, which may be perfectly normal, as part of the T waves. And we'll give you specific examples of that. You want to average a few beats, don't just take one, and use it during stable rhythm, because when you have changes in heart rate, it takes a while for the QTC to apply hysteresis and achieve a stable value. We use the Bizet formula, and just to remind you, the Bizet formula is the corrected QT. It's the QT, measured QT interval divided by the square root of the RR. Now, the computer is pretty good. The people at Mayo have actually done extensive studies looking at physician measured QTCs and the computer. And computer's right about 85% of the time, but it's not always right. And at times when it doesn't look kosher, then do your own measurements. They're very easy to do. You just measure the QT and then look up QTC calculations on your computer, and you can just quickly get the correct value. So in terms of how to measure it, the measurement is done from the onset of the QRS, and you use a tangent line from the end of the T wave back to the baseline. So this is the proper QT interval, okay? And for the corrected QT, you're going to do the QT over the square root of the RR. Now, there are things that will make things more difficult. The most common is the U wave. Now, the U wave is maybe due to many things, but I think most authorities now will attest that the U wave is due to repolarization of the Purkinje fibers, because the Purkinje fiber action potential is longer than that of ventricular muscle. So the tail end of it inscribes the U wave. Now, a U wave, which is less than 25% of the preceding T wave, is perfectly normal. And you'll almost always see that in V2, V3. You may see it in other other leads. So in measurement of the QT here, what you're going to do is take your tangent, go down the descending slope, and you're going to measure from the onset of the QRS to this value here. You're not going to measure here, okay? That's going to get you into trouble. Now, there are things like hypokalemia, where the U wave will be augmented, as you can see here. And then there are situations where you have what is like a split T wave or the camel hump, or it could be a TU. And when you're not sure, what you say is an abnormal QTU interval. We're going to learn about one of the forms of the QT syndrome, where this little hump here is actually pathognomonic of a form of the long QT. We'll get that back to that in a moment. But for now, what I want to emphasize is the correct way of measuring the QT. I got no questions about that. Okay. Okay, this is the Schwartz score, which is, I think, largely relegated to history. And before we had good genetics, what one would do is, of course, number one, measure the QT. That's the hallmark of diagnosis. And then we would look for the kind of arrhythmia, the Torsade pattern, which we'll talk about in a moment, and then whether it came out with stress and whether there were family members involved. And if you had a certain number, more than 3.5, then they said, okay, you had the long QT. Nowadays, the genetics are so good, we can identify mutations in 85% of the patients. So the big hallmark of the diagnosis is not only the clinical appraisal, but the genetics. And as we'll talk about later, the genetics are important not only for substantiating the diagnosis in your patient, but also for family screening. Very important. Okay, now let's spend a moment on pathogenesis of the long QT syndrome, because if you understand this, then you'll have a better grasp for treatment. So just a reminder of the components of the action potential. The action potential during the rest is around -80, -90 millivolts. Okay, so if you put a microelectrode into the cell, it'll be negative. The inside will be negative compared to the outside. And this is due to the IK1 current. And when you have depolarization of the cell, sodium rushes into the cell, positive ions rush in, the cell depolarizes, and actually there's a little overshoot. So phase 0 is when sodium rushes in, phase 1 is the overshoot. Then you have that plateau is when calcium comes in. Calcium moves a lot slower than the the sodium channel opens, sodium rushes in and then closes. Calcium channel is open 250, 200, 300 milliseconds. And so you get this plateau. And then you have outward potassium, which brings resting potential back down to normal. So if you visualize potassium going out of the cell, positive ions going out of the cell repolarizes back down to baseline. And then you have sodium, potassium, ATPase, which restores electrolytes back to normal situation. So the basic pathophysiology of the long QT is, for the most part, is loss of function of the potassium current. Very rarely you can have patients who have gain in function of the sodium or calcium. So if you have more positive charges, it takes longer to get out, action potential gets longer. So increased or gain of function of sodium or calcium can prolong the QT. Most commonly, they're due to loss of function of the potassium. Remember, the outward potassium current is what brings potential back down to normal, as we showed here. So if you have defective potassium currents, it takes longer to bring it back to normal. And the QT interval is a reflection of the action potential duration. That's the truth. The action potential duration is the truth. And what you look at in the EKG is the QT, which is a reflection of action potential duration. Okay, so in the top panel here, we see normal potassium exiting from the cell during the phase 3 of the action potential, bringing the resting potential back down to normal. If there are defective potassium channels, and the two big potassium channels that we are concerned with are so-called IKR and IKS. IKR current is defined as a potassium channel where, when from activation to peak current, is very, very short. So it's IKR, the rapid, whereas IKS from activation to peak is slower. And so those are the two potassium channels that we are concerned with. And these can produce prolongation of the action potential duration, as you can see here. And what happens is, with reopening of the calcium channel, calcium ions move into the cell, depolarize the cell, can give rise to an EAD, an early after depolarization, which, if sufficiently large, can give a PVC and very serious ventricular arrhythmias, so-called Torsade de Pointe, which we'll show you in a bit. But I just want to make sure this concept is clear. So for the most part, it's due to defective potassium channels. Action potential gets longer. Because it gets longer, it will allow for time for reopening of calcium channels and induction of these early after depolarizations, which, if they reach threshold, will give you a PVC and trigger serious arrhythmias. On the other hand, we have the people who have abnormalities in the sodium channel, where normally the sodium channel opens, and then you have a protein that shuts it closed, and this would be the proper or normal function. However, in the first genetic mutation defined for patients with the SCN5A sodium channel gene, what happens is, with loss of these amino acids, there's incomplete closure, and so sodium keeps dribbling in, and this will give you a long action potential. Now, the reason this is important is because treatment is different. In patients with The sodium channel abnormality, where there's gain of function, what you have in terms of treatment are drugs that will block the sodium channel, turn out to be very effective in shortening the QT in these patients. Now, this is the most dreaded arrhythmias that we worry about in patients with a long QT syndrome, so-called Torsade de Pointe. And this was described in the 80s by Dessertin. And he was a very imaginative Frenchman. And what he said was, look at this arrhythmia, you have turning of the points. Points are going up and down. In point of fact, it sort of depends on what lead you look at. So if you look at this lead here, you don't really see it. Here you see it beautifully. So what I like to say is that Torsade is really a beat-to-beat change in QRS. You might see a classic Torsade in a given lead, but the important thing is beat-to-beat change in the QRS. It's one of these polymorphic ventricular tachycardias, and oftentimes will lead into ventricular fibrillation. Now, notice this thing here. This is very important. What you have is an enormous QT, and you have T-wave alternans. When you see this, this is meant to tell you you can't sleep this night. Okay, so this is very worrisome because your patient is destined to get into trouble. This means there's great instability, there's inhomogeneity of refractoriness. So a given PVC can easily trigger. So what you're looking at is, this is the enormously abnormal QT interval. You have areas of differences in action potential duration from cell to cell. And this is your EAD, this is your PVC that triggers, and this is the Torsade. Now, in terms of the pathogenesis of Torsade, the theory that makes most sense is the one given by Anselevich, and this was a slide he kindly gave to me. And what you have is a PVC, usually begins in the endocardium. The mid-myocardium has the longest action potential, longest period of refractoriness. Epicardium is the shortest. So what happens is you have rotation of the impulse around the mid-myocardium. So you have electrical inhomogeneity, and a PVC will take care of, will initiate these very abnormal and serious cardiac rhythm abnormalities. Okay, so this is the pathogenesis of Torsade, which is the most worrisome arrhythmia for these patients. Now, there are a number of genes. I think we're up to about 12 genes at this point associated with the long QT syndrome. The ones that you want to remember, because these will be over 95% of the patients that you see, will be so-called LQT1, LQT2, LQT3. And it's important to know this because, again, it has implications in terms of diagnosis and treatment. So LQT1 is due to an abnormality in KCNQ1, that's the gene, and this controls the slow potassium current, IKS current. This is the most common genetic mutation found in long QT syndrome. LQT2, HERV or KCNH2 mutation. This is in the IKR, rapid potassium current. LQT3, which we talked about before, is the sodium channel, and this is a gain of function. The geneticist will talk about the loss of function and gain of function. And then very rarely you'll have Timothy's syndrome, which is a calcium disorder where you have increased calcium into the cell. This is very, very rare. Okay, so these three will explain the vast majority of the patients that you see with long QT. Now, there are some EKG clues. And in the old days, before we had genetics, or before it took, at the beginning of sort of at this field, only research laboratories would do the genetics for us. So we would send the sample in, and it would take 2 or 3 months before it comes back. Now we're living in a charmed life. We get results back in 2 or 3 weeks. It's incredible, for a very cheap cost. So anyway, so in the old days, it was very important, just looking at the EKGs, and the LQT3s have a long isoelectric interval and then a relatively normal T wave. So that's recognition of the LQT3 patients. The LQT2, these are the ones that have the T wave hump. There's the T1 and T2. This is the LQT2, or the IKR, the rapid potassium genetic mutation. LQT1 was the IKS, and this one has the broad T wave. So just looking at the EKG, you can get an idea of whether they fall into any one of these QT families. Now, why is it important? Well, it turns out that if you look at risk factors, the biggest risk factor, the big elephant in the room in terms of risk factors, is the length of the QT. Now, the QT gets over 500, you're meant to worry. Okay, either in the congenital long QT or in patients with a drug-induced long QT syndrome. So measurement of the QT is a potent factor. Now, the other potent factor is the type. So LQT1s are exquisitely sensitive to beta blockers, very, very effective. LQT2 are also responsive to beta blockers, but a little less so than the LQT1s. LQT3s are the least responsive. In addition, if you look at the mortality, the LQT2 and especially 3, these are the ones that have the biggest risk. So if you look at the patients with long QT who wind up with a defibrillator, nowadays are almost all LQT3s. So although it's a very small percentage of the LQT family, it is an important risk factor for sudden cardiac death because it's least responsive to beta blockers. However, as we'll point out, it is responsive to sodium channel blockers. This is if you want one article to look at, to review the clinical syndrome of long QTs, consult this Builder article in British Medical Journal in May of 21. And so here's the LQT1, 2, and 3. And here's the gene abnormality, which we discussed before, KCNQ1, KCNH2, SCN5A. And this one affects the IKS current, slow potassium. This is the rapid one. This is the sodium one. They all prolong action potential duration. LQT1 is the most frequent. And the EKGs we discussed. Now, it's interesting in patients where you strongly suspect long QT, however, they are gene elusive. You can't find the gene, which happens 15, 20% of the time. You can't find the gene. Exercise may be very helpful. In patients with LQT1, typically they don't shorten with exercise. With exercise, what happens is as you increase the heart rate, the QT will shorten normally, okay? Will normally shorten. The reason for that is basically the LQT, the IKS current takes longer time. So the faster you exercise, you build up the IKS current, and it will tend to shorten it with exercise. So that's the normal response. These patients will not shorten. So that's a very important clue. So, and with the LQT2s will have a normal response to exercise, and the LQT3 will actually have a supernormal response. Now, clinically, also there are clues as to which one of the QTs you're dealing with. So, for example, if you have a history of I jumped into the swimming pool or I was swimming and then I had a syncopal episode, that's pathognomonic LQT1, exercise related, particularly swimming. LQT2, the important clinical component is arousal, rapid arousal from sleep. So the typical history is I was working all day, I was taking care of my patients, I went to sleep, the alarm clock rose, and then I have my seizure or syncopal episode or whatever, or cardiac arrest. So in the LQT2s, it's auditory, and now LQT3s invariably occur at rest. So these three clinical manifestations are also helpful. Age of onset, they all begin either in childhood or in puberty. And of interest, the LQT1s are not pause dependent. You just have a PVC that triggers, as I showed you before. The LQT2s are pause dependent. Typically, you have a PVC, post PVC pause, and then you get a PVC afterwards that triggers. So if you see this is strongly suggestive of an IKR abnormality. This pattern is also seen in the drug-induced ones, because the drug-induced long QTs are like the IKR, because what happens is IKR has a very capacious vestibule, so it's very easy for drugs to get stuck in there, so that the clinical manifestations of your long QT due to acquired forms, drug forms, or electrolyte forms are mainly IKR related, LQT2 type related. And treatment, as we said before, beta blockers are very, very effective in LQT1. If they don't work, there is a left stellectomy where you can go in and dissect out the left stellate. And this is like a super beta blocker for people who can't take beta blockers. The LQT2 are responsive to beta blockers, also left stellectomy, and then potassium supplementation. And for the LQT3, here we use beta blockers, but they're least effective, and it's important that they get some sodium channel blockers. We'll talk about specific ones. So in summary, treatment of patients with congenital long QT, beta blockers are most effective for LQT1, LQT2. If they fail or are intolerant to beta blockers, we think about sympathectomy or even putting in an ICD. ICD is an internal cardioverter defibrillator. For those treated with an ICD, I usually use a dual chamber because we use atrial overdrive pacing. Atrial pacing in normals and in long QT patients, as our own studies have shown, will shorten the QT. Okay, so we use, for the resistant cases, we'll use triple therapy. We give them beta blockers, we have pacing to shorten it, then we have a backup defibrillator. That's the most intense treatment. You want to avoid drugs that prolong the QT. We have a big clinic of patients with QT, and they usually do very well. The things that get them into trouble is they'll have a GI upset and they lose potassium. They, I was on a cruise, I had a stomach upset, and suddenly I had my syncopal episodes or my seizures or what have you. So we really warn them. We caution them to go home and always have either Gatorade or some electrolyte. And if they can't control GI losses, get to the emergency room. You don't fool with it. Number two, you avoid the drugs that prolong QT. And this is very well documented. There is a number of internet sites that will give you drugs that prolong the QT and those that have been associated with Torsade. So if ever you're unclear, look up creditabledrugs.org, and that will give you a good idea of the drugs that can make things worse. Very important. This is very different from a patient comes in with pneumonia or heart failure, and you treat that patient. Remember, for these patients, you're treating the family. So it's very important that you refer them to the genetic arrhythmia clinic that we have here. There we have trained genetic counselors, and they will contact all first-degree relatives. That's part and parcel of treatment of the long QT. It's not just treating this patient, you're treating the family. So you bring them all in and you identify those patients who are affected who have the gene mutation. Now there's a benefit in those who have the LQT3. Those are the ones where you have increased sodium channel. It's been shown that the sodium channel blockers will decrease the QT in animal models. It's also been shown to be effective in LQT3, and the most popular drug is used is mixilotine. Flecainide and ranolazine have been used, but the latters have some other potential side effects as they can block IKR. So mixilotine is sort of the drug of choice, but you can use flecainide if you carefully watch the patient as well. So as a sort of a summary here, you have patients who come in with a long QT syndrome. If they present with cardiac arrest, they get a beta blocker and a defibrillator. If you have a class 1 patient, cardiac arrest, and it's LQT1, you can, after talking to the patient and family, you can use beta blockers if they don't want a defibrillator, because as we said, the beta blockers are very effective. If they don't respond to the beta blockers, we think of left cardiac sympathectomy. The patients who are asymptomatic, so these are the family members. What do you do with the family members? Well, we tend to treat all of them. So if the patient carries the gene mutation, we'll put them on treatment as well, even though they're asymptomatic. Now, a word about the long QT syndromes. There are many, many drugs that are associated with long QTs. And just as a brief review, the antiarrhythmic drugs are probably one of the more important villains, particularly the 1A drugs like quinidine, procainamide, or class 3 drugs like sotalol, drugs that prolong action potential. And then the phenothiazines and numerous antibiotics, which I think you're all familiar with. Antihistamines are no longer a problem because those have been taken off the market. Remember, you can get long QTs. The biggest villain is the low potassium. Look out for that. And these are the patients that come in, have a long QT, and they'll have U wave, ST depression and U wave. Think of hypokalemia as the underlying cause, because the treatment obviously is very indifferent. You can get an acquired long QT with severe bradyarrhythmias and other situations. Now, again, with the drug-induced ones, these are the ones that the pattern is like an IKR or LQT2. They are pause dependent. So here's the typical pattern. You have your PVC, you have a pause. Remember, the pause will further prolong the QT, and that gives rise to an EAD of the PVC, and here's your Torsade. Now, treatment of the drug-induced, which is really very important for you guys, because you're going to be seeing these sick patients post-op on a number of drugs and electrolyte problems. That's why you got to really think of LQT, and it's sort of always got to be something you want to rule out straight away. So you want to look at the EKG carefully, and in treatment, you obviously want to discontinue the offending drug. So if you see a long QT in a sick patient, arrhythmia, polymorphic VT, we're going to look at the drugs that the patient is taking. What are they taking? Look at the electrolytes. Correct the electrolytes, particularly potassium levels. Treatment of choice is IV magnesium. Okay? IV magnesium counteracts the effects of the lower potassium. It blocks calcium entry, and it's very effective. Other thing that's very effective is temporary transvenous pacing. I like that better. There are some authorities will say use isoproterenol in urgent situations. The problem is with isoproterenol is you can trigger PVCs, which can make things worse. So in an emergency situation, in a young, healthy individual, I think it's okay to use the isoproterenol, like in the emergency room. You got to do something really quick. But if you have any kind of time, call cardiology, get a temporary transvenous pacemaker. I like to put the pacemaker in the atrium, because again, as you put the catheter in the ventricle, you start PVCs, and it can trigger problems. Okay, so get the cardiologist to come in. They can put the catheter. They have catheters that can be put against the wall of the right atrium or slide it into the coronary sinus and do atrial overdrive pacing. Either way is effective. Now, one thing that I wanted to talk to, because this comes up all the time, because as cardiologists, you're going to be confronted with the patient who comes in with long QT syndrome, and they really want to exercise. I can't tell you how often when I was seeing patients in the clinic, how devastated they are when you tell them, well, you have the long QT syndrome, you can't exercise. And that was the guidelines many years ago. That was what, because it's true of anything we do. When we're not sure, we tend to be very conservative, and we say, you can't do this. I remember when we started the coronary care unit here, you would not allow the patient to do anything. The nurses fed the patient. They were kept in oxygen tents, and nurses fed it, and it did more harm because they developed all kinds of arthritic problems and thromboembolic situations and so on. So, and the same is true with exercise. There's two retrospective studies with exercise, and both of them suggested that exercise was not a problem. The best study is by Rachel Lampert, who's done incredible work, use of ICDs and treatment in patients who want to exercise. And this was a prospective study of patients with congenital long QT, where they compared vigorous exercise from those who were basically sedentary. And I'm not going to read the whole thing, but the long and short of it is that when you look at the ones who had problems, first of all, these are patients who are all treated, but 91% were treated. So that's very important. We're not talking about the untreated patient with long QT. We're talking about patients who are treated, either ICD or beta blockers, both. And it turns out that the ones who exercised, and if you compare if they had problems, which was very few, if you compare it to the exercise to periods where they were at rest, it didn't make any difference. So this has helped us a great deal. And so nowadays, the recommendations are, number one, we can consider continuing vigorous exercise in patients with long QT if, number one, they're compliant with beta blocker therapy, very important. Adequate hydration, electrolyte management, no QT prolonging drugs, and access to ICD. So nowadays, the idea is a shared decision-making. You bring the patient, the family in, you talk to them and say, okay, you want to play soccer, competitive soccer, football, whatever, it's perfectly all right. However, we've got to bring the coach in. We have to make sure that there's access to an ICD and make sure that you're compliant with treatment. So our approach has changed tremendously in terms of exercise. And this is a big thing because these are young, healthy people and they want to exercise. And some, it's their whole life. I had one fellow, for example, who was a quarterback in college. It was his whole life. He wanted it was his career. So it's not a trivial thing. Now, the other thing that's of interest is in athletes, and this is not well appreciated, but in athletes, trained athletes, they can have QTCs that are borderline prolonged. Okay? That's really very important. And when you're not sure, of course they're gene negative and everything's fine. And if you're not sure, what you do is you train them. Okay? You tell them you can't exercise for 4 weeks, 8 weeks, and then you measure the QT, and lo and behold, it's perfectly normal. So very important. Keep that in mind. People with exercise can do it. There's one other point that's important that I failed to make in patients with drug-induced Torsade, and that is the important work that's shown that you can have patients who have a perfectly normal QT, but when exposed to drugs, they develop long QT and may develop serious arrhythmias. These patients may be form fruits of congenital long QT. So it's always well to check their genetics and family history. Okay? So the drugs can unmask a congenital. I forgot to mention that when we talked about that. So it's important to keep that in mind. Okay, so since we have a little bit of time left, I'm going to introduce one other topic very briefly, and that is the total opposite of what we've been talking about. This is the short QT syndrome. And they may give you this on the boards, but you'll never see a patient with it. This is very rare. Believe me, I've run the genetic arrhythmia program here for over 15 years, and we have one family that has it, and they never had an arrhythmia. But this is absolutely typical. Look at it. Do you see the QT interval is very short? You can see that? And typically they're less than 330 milliseconds. And then you get this great big peak T wave. Okay. Now, this can be very, very symptomatic. It's an important cause of sudden cardiac death in children. They can present with AFib, BFib. So very important to keep this in mind. And the short QT syndrome is very rare, and it's due to a gain in function of potassium right? Because all the things we said, most of the long QTs are loss of function, actually, it's longer. But if you have a genetic mutation where you have gain of function, your QT will shorten, and you can get the clinical manifestations like sudden infant death and VF and AF. That's all I have to say about the QT syndromes, and I'll be happy to try and answer any questions.